Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we'll be breaking down the nerves of the upper limb into clear, high-yielding, exam-oriented concepts. So let's get started. The nerves of the upper limb, when we say, we have the axillary nerve, then we have the musculocutaneous nerve, and here posteriorly we have the radial nerve, the median nerve mainly in the forearm, the ulnar nerve, as well as a branch of radial nerve on the posterior aspect of the forearm, which we call it as the posterior interosseous nerve. So these are the main nerves of the upper limb. And all these nerves of the upper limb, they begin from the brachial plexus. So brachial plexus is formed by the ventral rami of C5, C6, C7, C8 and T1 spinal nerves. Sometimes it may receive a contribution from C4 or T2, which we call it as prefixed or postfixed respectively. So let's see each of these nerves briefly about their course and their distribution and what will be the lesions if these nerves are injured. Okay, so what signs and symptoms we see when each of these nerves are injured. So first, coming to the axillary nerve. So the axillary nerve is a branch of the posterior cord of brachial plexus. So what will be its root value? Its root value will be C5 and C6. So this axillary nerve mainly supplies the structures around the shoulder joint. So now once this axillary nerve is given by the posterior cord of brachial plexus, it runs across the subscapularis muscle and through the quadrangular space here. Okay, so we'll have the quadrangular space in this region. So it passes through the quadrangular space along with the posterior circumflex humeral vessels, and it is closely related to the surgical neck of the humerus near the cervical. So if the cervical neck is injured, so this axillary nerve is also injured along with it. So cervical neck of humerus. So it's in close relation to this cervical neck of humerus. So where it will divide into an anterior and posterior divisions. So we'll see the distribution of each of these divisions. So here this is schematically, we will see now this is the C5 and C6 root value. From the posterior cord of the brachial plexus it begins. So any nerve, always like when we look at the branches of the nerve gives muscular or motor branches. It gives sensory or cutaneous branches. Then it also gives articular, that is to the joints, and vascular to the vessels. So usually a nerve gives all these branches. So here the axillary nerve, it supplies among the articular, it supplies, since it is in close relation to the shoulder joint, it supplies the shoulder joint. So after supplying the shoulder joint, it divides into an anterior division and a posterior division. So it divides into an anterior division and a posterior division. So the anterior division will supply the deltoid muscle. Okay, it supplies the deltoid muscle and then it continues as a cutaneous branch to supply the skin over the lower half of skin over lower half of deltoid. So in this region it supplies. Whereas the posterior division, it gives a branch to teres minor muscle and it continues as the upper lateral. So it continues as the upper lateral. So this is the upper lateral cutaneous nerve. So it basically supplies the skin over the lower lateral part of the deltoid, lateral part of the deltoid. So the anterior and posterior divisions, after supplying the muscle, they end up as cutaneous nerves. So here the posterior division which supplies the teres minor branch which supplies the teres minor, it ends up like it has a pseudoganglion. So when we say ganglion is a collection of cell bodies of the nerve outside the central nervous system. This is not a collection of nerve cell bodies. Since it is just a small swelling there, we call it as the pseudoganglion. So this is the course and distribution of the axillary nerve. So thus we have the muscular or motor branches to two muscles, the teres minor as well as the deltoid. Sensory branches basically to the upper lateral aspect of the around the shoulder, that is around the deltoid region, as well as the lower part of the deltoid skin over the lower half of the deltoid. So that is the sensory distribution. Articular is mainly to the shoulder joint, and vascular, which will supply the vessels in that region, mainly the posterior circumflex humeral vessels. So now let's see the injuries. So when the axillary nerve is injured, the main muscle which are involved will be the deltoid and the teres minor. So here when the deltoid muscle is mainly affected, so here you can see there is loss of the contour, okay, loss of contour of shoulder joint. Okay, so and you can see the prominent acromial process here. The acromial process becomes prominent with loss of contour. So if you observe the right and left shoulder joint, you can see here the depression. So there is the loss of contour because of the atrophy of the deltoid muscle, which is, or paralysis of deltoid muscle, which is involved. Then here and wherever the cutaneous supply is there, okay, so along the upper lateral part as well as little posterior here near the insertion, this is the lower half of the skin over the deltoid region. So here there is cutaneous loss, cutaneous sensation loss, okay, so sensory loss is seen in this region. Then the main action, okay, there is also what we call it as the regiment badge sign. So regiment badge sign is in the army people, the soldiers, okay, and the officers in the army. They have the regiment badge which is tied across the arm, upper part of the arm. So compression of the axillary nerve by this regiment badge, which results in loss of sensations or tingling sensations in this region, in the upper lateral area. Okay, so tingling and loss of sensations will happen in this region. Okay, so that we call it as the regiment badge sign. Then since other thing which will be affected is because the axillary nerve is involved, which supplies the deltoid muscle. Now, deltoid muscle is responsible for what action? It is responsible for the abduction. So, abduction between 15 to 90 degree is mainly by the which muscle? The deltoid muscle. So, because this nerve is involved, the axillary nerve which supplies the deltoid muscle is involved and deltoid muscle is paralyzed there, what will happen? There is loss of abduction. Okay, so first 15 degree is brought about by the supraspinatus. So, rest of the abduction is by the deltoid and that is lost. Okay, so these are the signs and symptoms which we see in the axillary nerve injury. Right, so just to recall, there is loss of contour. There is loss of contour on the shoulder joint. Then there is cutaneous loss, the upper lateral part, and there is loss of abduction, as well as there is neuropathy in this region, okay, where the regiment badge, in case of regiment, that is which we call it as the regiment badge sign. Next, coming to the next nerve, that is the musculocutaneous nerve. So, musculocutaneous nerve, it arises from the lateral cord of brachial plexus. So, the root value of it is the main nerve from there. So, the root value will be C5, C6 and C7. So, this nerve, after it emerges from the lateral cord, it pierces through the substance of the 𝗧𝗏𝗏𝗃𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 muscle. So it pierces through the substance of 𝗧𝗃𝗧𝗃𝗧𝗃𝗃𝗧 muscle, then runs between the biceps and the brachialis muscle. Okay, and along the lateral part of the tendon of the biceps, it will continue as in the lower part, that is near the cubital fossa region, it will continue as the lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm, supplying the front as well as the lateral aspect of the forearm. So, since it is both muscular, mainly in the anterior compartment of the arm, and becomes cutaneous in the forearm, we call it as the musculocutaneous nerve. So, what happens in injury of this musculocutaneous nerve? So, musculocutaneous nerve injuries are rare, but if it happens, then there is loss of, okay, so when we see here, this is the musculocutaneous nerve. So, the root value is C5, C6 and C7. So, here it pierces the 𝗧𝗃𝗃𝗧𝗃𝗃𝗧𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 biceps as well as the brachialis muscle, and in the articular it supplies the elbow joint and continues, pierces the deep fascia, becomes cutaneous and continues as the lateral cutaneous nerve of forearm. Okay, so these are the branches. So muscular basically to the all the anterior compartment muscles of the arm. So anterior compartment muscles are mainly the flexor muscles, and among them biceps is also a supinator. So what will happen if the nerve is injured? So among the motor loss, we will see the loss of strong flexion and supination. Then cutaneous loss we will see along the front and lateral aspect of the forearm. Okay, so there is cutaneous loss on the front and lateral aspect of forearm. Elbow joint here is affected. And vascular, it supplies the vessels in the arm region, in the anterior compartment of the arm, basically the brachial artery and the vena comitans along with that. This is about the nerve supply as well as the signs and symptoms of musculocutaneous nerve. So when we see here, we can see there is, because of the loss of flexion, there is the loss of tendon reflex, biceps tendon reflex. Okay, and you can see along its distribution, that is the front and a lateral aspect. Okay, we'll see the cutaneous loss. So this is about the musculocutaneous nerve. So main thing you have to remember here to recall about musculocutaneous nerve, it is the branch of the lateral cord of brachial plexus having the root value of C5, C6 and C7. And there you see it mainly piercing the 𝗘𝗅𝗵𝗶𝗃𝗧 muscle and supplying all the muscles, the rest of the two muscles, that is the biceps, as well as the brachialis in the anterior compartment, and continues as the lateral cutaneous nerve of forearm in the forearm region, anterior compartment of the forearm. So here the muscular supply is mainly to the anterior compartment muscles, and when it is affected, if it is injured, then there is loss of biceps, tendon reflex, the loss of flexion and supination, and the cutaneous loss will be mainly along the front and lateral aspect of the forearm. So that is the main signs and symptoms of musculocutaneous nerve injury. So let's move on to the next nerve. Now let's study the largest branch. Okay, so the largest branch of the brachial plexus, which is also the largest nerve of the upper limb, and that is the radial nerve. So radial nerve is the, remember, it is the largest branch of brachial plexus as well as the largest nerve of upper limb. So in the brachial plexus, it begins from the posterior cord. Okay, so it is basically the continuation of posterior cord of brachial plexus. So it has the root value of C5, C6, C7, C8 and T1. So it begins in the axilla, okay, axilla from the posterior cord of brachial plexus. So in the axilla is basically lies behind the third part of axillary artery. So from there it passes through the lower triangular space. Okay, so it enters the arm below the lower border of teres major muscle. Okay, so below the lower border of teres major, it will enter, that is through the lower triangular space, it will enter the posterior compartment of the arm, where it will pass through the spiral groove along with the profunda brachii vessels. So it passes through the spiral groove along with the profunda brachii. Okay, so you have to remember that in the spiral groove, it is accompanied by the profunda brachii vessels. So after passing through the spiral groove, as it comes out, it pierces the lateral intermuscular septa and again enters the anterior compartment of the arm. So there it will supply the brachialis muscle, which is actually a muscle of the anterior compartment. So brachialis muscle, we call it as hybrid because it has both nerve supply from the musculocutaneous as well as from the radial. So it supplies the brachioradialis as well as the extensor carpi radialis longus muscle, and at the level of the lateral epicondyle of the humerus, it will divide into two. branches, that is the D branch, which we call it as the posterior cutaneous nerve. Okay, so there it will divide into, one is the posterior interosseous nerve, posterior interosseous nerve, and the superficial branch which we have, okay, superficial branch, superficial radial branch. Okay, so this branch is also called as the superficial radial nerve. So that is in brief about the course of the radial nerve. So let's see schematically how, here just to note the posterior cutaneous nerve, you can see it will pass through the substance of the supinator. Okay, so here we have one arcade, okay, which we call it as the arcade of Froissart. So this arcade of Froissart is basically a fibro-aponeurotic passage, okay, so which we see here when the posterior cutaneous nerve enters the forearm. So let's now see the course of the radial nerve. So we see it beginning from the posterior cord of the brachial plexus, with the root value of C5, C6, C7, C8 and T1. So now we will see its course in the, when it passes through the axilla. So in the axilla, it will give one cutaneous branch. Okay, so in the axilla, I said it will lie behind the third part of the axillary artery. And then at the lower border of the teres major muscle, it will pass through the lower triangular space and enters the posterior compartment of the arm, posterior compartment of the arm. So before that, it will give, before it enters there, it will give a cutaneous branch, which we call it as the posterior cutaneous nerve of arm. So the posterior cutaneous nerve of arm supplies the skin over the posterior part of the arm. Okay, so sensory innervation to the skin over the posterior part of the arm. And it will give a muscular branch to the long head of triceps. And sometimes some books mention as it also gives to the medial head of triceps. So this you have to remember when we talk about the injuries. So the long head of triceps, which is the extensor of the elbow joint, it is the nerve supply is given before it enters the spiral groove. Okay, spiral groove. So after it enters then in the arm, it will pass through the lower triangular space, enter the posterior compartment of the arm. There it will be running in the spiral groove. Along with the profunda brachii vessels. So here it will supply, so this is the profunda brachii vessel here. So in the spiral groove, it will give branch to the medial head, the lateral head of triceps. Then it gives the lower lateral cutaneous, okay. It gives a cutaneous branch, that is lower lateral cutaneous nerve of arm. So upper lateral cutaneous nerve of arm was given by which nerve? The axillary nerve. So lower lateral cutaneous is given by the radial nerve. It supplies one of the extensor muscle, that is a short extensor muscle, which we call it as anconeus. Okay, it supplies anconeus, and then it gives the posterior cutaneous nerve of forearm. Okay, posterior cutaneous nerve of forearm. then pierces the lateral intermuscular septa and then enters the anterior. So from posterior compartment it comes to the anterior compartment of arm, where it will supply the brachialis muscle, then brachioradialis muscle, and then the extensor 𝗘𝗵 radialis longus muscle. So these muscles it will supply before it divides into its branches. Okay, at the level of the lateral epicondyle of the humerus, it will divide into its two divisions. So this is the course of the radial nerve as such, the main radial nerve. Okay, so in the spiral groove, in the arm, okay, the branches given by it is mainly the two cutaneous nerves and then the muscular branches. So cutaneous nerves, it gives the lower lateral cutaneous nerve of arm and posterior cutaneous nerve of forearm. And muscular branches, it gives to the anconeus, and then in the anterior compartment it will give to the brachialis, brachioradialis and extensor 𝗘𝗵 radialis longus. Then once it divides, okay, so once it divides into the posterior interosseous nerve or the deep branch, okay, which we call it. So here we can see, so in the forearm we will see two branches. One is the posterior interosseous nerve, another one will be the superficial branch or superficial radial nerve. So this is the deep branch, the posterior interosseous nerve. Okay, so the posterior interosseous nerve in the cuboidal fossa will supply two muscles, that is the extensor 𝗘𝗵 radialis brevis muscle and the supinator. So once it supplies these two muscles, it passes through the substance of the supinator and then supplies all the rest of the extensor muscles. So we have the extensor 𝗘𝗵 radialis brevis and supinator already supplied. The rest of them, that is the extensor digitorum, the extensor digiti minimi muscle, then we have the extensor 𝗘𝗵, these are all the superficial, extensor 𝗘𝗵 ulnaris, then we have the abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, as well as the extensor indicis. So these are the deeper muscles, these superficial group. Okay, so all the extensors are supplied. Okay, and it also supplies two joints. It gives articular branches to the inferior radio-ulnar joint as well as to the wrist joint. So that is the course of the posterior interosseous nerve. Whereas when we see the superficial branch, okay, the superficial branch is mainly sensory. So it will not supply the skin over the forearm. It runs downwards across the supinator, the pronator, teres muscle, then the flexor digitorum, superficialis muscle, and deep to the brachioradialis along the lateral aspect. And about 7 centimeters, okay, about 7 centimeters above the wrist, it passes posteriorly. It passes posteriorly and it emerges behind the tendon of the brachioradialis, passes over the tendons of the anatomical snuff box. Okay, tendons of those, and then it terminates as the cutaneous branch. So cutaneous, it will supply, so all these tendons, so here you passes, this is the tendon of the brachioradialis, then passes over the tendons of these tendons, they form the boundaries of anatomical snuff box. We have abductor pollicis longus, then extensor pollicis brevis and extensor pollicis longus here. Okay, and then it terminates as the cutaneous nerve, where it will supply the skin over the lateral side, okay, dorsum, lateral side of dorsum of hand, as well as the 3.5 lateral 3.5 fingers up to the nail bed, okay, except the nail beds. Except the nail beds, it will supply the skin over the dorsum of the hand as well as the lateral 3.5 digits up to the nail bed region. The nail bed region is supplied by median nerve. So this is about the course and distribution of the radial nerve and its branches. So now we have to understand the injuries. Okay, so the radial nerve is injured at 3 sites mainly. Right. So here we can see the sensory supply, lower lateral, part of arm, posterior part of arm, as well as posterior cutaneous nerve of forearm, and through its branch the dorsum lateral part as well as the 3.5 digits up to nail bed, except nail bed. Okay, so remember that it doesn't supply the nail bed region, that is over the distal phalanx it is not supplied. So when we look at the injury of the radial nerve, it occurs at 3 sites. So one in the axilla, so it can be injured in the axilla, it can be injured in the spiral groove, as well as it will be injured at the level of the elbow. So these are the 3 sites of injury of radial nerve. Okay, so this is both about the sensory supply which we can see. A small portion here on the palm also it will supply near the base of the thumb, as well as here you can see at the dorsum. Okay, so this is near the base of thumb, as well as the dorsum of hand, lateral part, and 3.5 digits. Okay, so 3.5 digits it supplies up to here. Okay, so up to the base of the nail beds. Okay, so up to the nail bed region it will supply, that is basically the region over the distal phalanx is not supplied on the dorsal part. So coming to the injuries, I told you at 3 levels it can be injured in the axilla, at the level of the spiral groove, at the elbow. Right. So in the axilla, so axilla it basically we call it as the crutch. So in the axilla, when it is injured, we call it as the crutch palsy. So basically in people who walk with the crutches, right? So there is continuous compression of the radial nerve there in the axilla and it can result in crutch palsy. So here characteristic clinical features. Now in the axilla, what were the branches given by the radial nerve? Radial nerve gave one cutaneous branch, which was that the posterior. So here if we go back, in the axilla it supplied the posterior, it gave the posterior cutaneous nerve of arm, and it also gave 2 muscular branches, that is mainly to the long head of triceps and maybe sometimes to the medial head of triceps too. So that was the main thing. So what happens here now? There is motor loss, there is sensory loss. So motor loss is mainly where motor loss because the triceps is affected. So triceps is responsible for the extension of the elbow joint. So what movement is lost? Extension of the elbow joint is lost. So if you see the injury, okay, so there is extension of the elbow joint. And if you see the remaining course, okay, the entire course is affected, right? If the nerve is injured at the axilla level itself, where it is beginning, So in the axilla, since it gives the posterior cutaneous nerve of arm as well as the triceps, so we have the loss of extension, we have the cutaneous loss over the posterior aspect. Now since it is the beginning, the rest of the distribution, the area of supply is also affected. So what are the other things affected? All the extensor muscles are affected and the cutaneous loss is also there, right? So here the cutaneous loss, so what we have to understand is, if the nerve is injured in the axilla, so what are the cutaneous losses? What is the motor loss? So first let's see the cutaneous loss. So cutaneous loss, when we see, okay, we will see the cutaneous loss as well as the motor loss. Okay, so cutaneous nerves, which are the cutaneous nerves now of the cutaneous supply by the radial nerve? We have the posterior cutaneous nerve of arm, the posterior cutaneous nerve of forearm, and it also gives the sensory, that is lower lateral cutaneous nerve of arm. So three nerves mainly we have, and its branch, that is the superficial radial branch, okay, which supplies the skin over the dorsum of the hand as well as the 3.5 digits, right? So that it supplies. So if we go from above downwards, we have loss. First is because of the involvement of posterior cutaneous nerve of arm. We have loss of sensation over the arm. Okay, loss of sensations on the posterior aspect of arm. Posterior aspect of arm. Okay, then we have the posterior cutaneous nerve of forearm. So even on the forearm there is loss of sensation as arm as well as forearm. Then it gives lower lateral cutaneous nerve of arm. So in the lower lateral region of arm, again the cutaneous innervation is affected. Then we have the superficial radial nerve, which is again the cutaneous branch of the radial nerve, which supplies the skin over the lateral part of dorsum of hand as well as the lateral 3.5 digits. So these sensations are affected. The motor loss, where do we see? We see it in all the extensors. Okay, so there is loss of extensors. So loss of extension of the elbow because of the triceps involvement. So elbow extension is lost. Then loss of extension of wrist due to paralysis of the wrist extensors. Okay, so and that will lead to wrist drop. Okay, so there is unopposed action of the flexors. So wrist is dropped. So that is known as the wrist drop. And there is loss of supination in extended forearm. Okay, when the loss of supination when the in an extended elbow. So when the forearm is extended, right? So there is loss of supination, because when the elbow is flexed, the supination is brought about by the biceps. Okay, so the biceps muscle, biceps brachii muscle, it is a strong flexor as well as supinator of the elbow, but that is in the when the elbow is flexed. When the elbow is extended, it is mainly the supination action is by the supinator muscle, which is supplied by the radial nerve. So that is affected. Okay, and there is loss of extension of the digits. Loss of extension of the digits mainly because the extensor digitorum, the extensor indicis, the extensor digiti minimi, as well as the extensor pollicis longus, all of them are affected. So because of which there is loss of extension of the digits also. Not only here, the extension of the digits is also lost. So this is about the cutaneous and the motor loss when the nerve is injured in the axilla. So the entire nerve and its distribution is affected. Now if it is injured in the spiral groove, just here you have to know what is not lost in the spiral groove. So before it enters the spiral groove, what were the branches given? One was the posterior cutaneous nerve of arm and one to the triceps, isn't it? So two branches were given. So because of which, what happens? The sensations over the posterior cutaneous nerve of arm is not lost. Okay, the whichever distribution of posterior cutaneous nerve of arm is there, right? So basically on the posterior aspect of the arm, there is no sensory loss. And where the motor loss, which is spared, the triceps action, because the long head of triceps is supplied before it enters the spiral groove. So because of which there is though there is little weakness in the elbow extension, there is no complete loss. So usually radial groove injuries, okay, in the radial groove the nerve can be injured, okay, in the radial groove or spiral groove. The nerve can be injured because of the mid-shaft fracture. So in the radial groove, the nerve may be injured mainly due to, one is the mid-shaft fracture, then direct pressure of the radial nerve by a drunkard falling asleep over the arm on the back of the chair, okay, back of the chair. So that is known as the Saturday night palsy, okay, Saturday night palsy. So compression, and the patient sleeps with the arm over the chair, okay. So usually we say drunkard because they will be losing their senses and they will be just lying down, and since it is usually people get drunk, relax during the weekends, we call it as the Saturday night palsy here, okay. So that is why Saturday there, Saturday night. And this is mainly in the spiral groove, okay. So in the spiral groove, if the nerve is injured, the actions which are spared are mainly the nerve supply over the posterior aspect of the arm, okay. So posterior aspect of the arm, the sensations are not lost. And other thing which is not lost is the elbow extension. So there will be a weak elbow extension because of the sparing of the triceps, long head of triceps. So remember that long head of triceps is spared, so because of which there is no complete loss of extension in injuries of the radial nerve in the spiral groove, okay. There is no complete loss of extension of elbow. But wrist drop is there. Wrist drop we will see, okay, because the extensors of the forearm are affected. Then the third level of injury is injury at the elbow, okay. So at the elbow what happens? It is mainly known as the radial tunnel syndrome. So here is basically it's an entrapment neuropathy of the deep branch of radial nerve. So this is mainly because of four things. One is the fibrous bands. The fibrous bands can tether, okay, the radial nerve in the so fibrous bands may be present there which can tether this radial nerve here to the radiohumeral joint. Next, the sharp tendinous margin of extensor carpi radialis brevis muscle can also cause pressure there. Then leash of vessels, okay, leash of vessels from the radial recurrent artery. So these vessels can also compress, okay, over the posterior interosseous nerve branch, and it can cause injury there. And other thing is the arcade of Frosse. When it passes through that arcade of okay, so this arcade of Frosse we see here, it's a fibroaponeurotic proximal edge of the superficial part of the in the supinator muscle, okay. So here the characteristic clinical features which we see, mainly there is the loss of extension of the wrist. So here there is loss of extension of the wrist, but as such the wrist drop is not there because some of the extensor muscles are spared here. So there is a little bit of power there, and because of which there is no complete wrist drop. And since it is mainly the posterior interosseous nerve which is affected, it's basically the entrapment syndrome. There is compression, there is no complete injury there, right? So because of which there is also pain, the pain over the distribution, extensor aspect of the forearm. So these are the injuries which we see because of radial nerve. Okay, so radial nerve mainly we have the crutch paralysis when it is injured in the axilla. Then we have the Saturday night palsy when it is injured in the spiral groove. Okay, and then we have the nerve entrapment, that is radial tunnel syndrome or nerve entrapment syndrome, which involves the posterior interosseous nerve. So that is the main thing. So motor loss in case of radial nerve injury is mainly we will see the loss of extension of the elbow if it is injured before it passes through the spiral groove. If it passes, then if the injury is in the spiral groove onwards, then we see the loss of extension, okay, of the wrist, loss of extension of the fingers, okay. So loss of extension of wrist which results in wrist drop, and there is also loss of extension of the fingers, the digits, because of the involvement of the extensors of the digits. Then the cutaneous loss we will see along the lower lateral part here, okay. So this portion, lower lateral part. Then posterior cutaneous, this one is spared if the injury is in the spiral groove. If the injury in the axilla, then even this is involved, okay. So this will be spared if the injury is in the spiral groove. Okay, so this will be spared. But if it is in the axilla, then this cutaneous distribution is also affected. Then the rest of them are all affected, the posterior cutaneous nerve of arm and to the superficial sensory radial nerve, which supplies the skin over the dorsum of the hand, a little portion over that near the base of the thumb, dorsum of the hand, the lateral part, as well as the lateral 3.5 digits. So all of this is affected in the radial nerve injury. The next nerve we will look at is the median nerve. The median nerve, when we say, it is also from the brachial plexus. It arises from brachial plexus, but by two routes. That is, we have the lateral root which comes from the lateral cord and the medial root which comes from the medial cord. So both of these join to form the median nerve. Okay, so this is formed in front like a Y-shaped, okay, Y-shaped. It is formed in front or on the lateral aspect of the axillary artery, the median nerve in the axilla. So basically the root values of this, since it arises from both the lateral cord as well as from the medial cord, because the lateral root is coming from the lateral cord of brachial plexus and the medial root is coming from the medial cord of brachial plexus. So the root value of median nerve will be C5, C6, C7, C8 and T1. So in the axilla, so if you see the nerve in the axilla, the median nerve will lie on the lateral side, okay, will lie on the lateral side of the axillary artery. It will lie on the lateral side of the third part of axillary artery, okay, third part of axillary artery, and then it enters the arm at the lower border of the teres major muscle. So in the arm, what happens? So this in the arm, the median nerve lies lateral to the brachial artery. So first it lies lateral to the brachial artery. This is the brachial artery. So it first lies lateral to the brachial artery, then crosses in front of the artery from the lateral to the medial side. and that is at the level of the insertion, mid-humerus level, which is at the level of the insertion of the 𝗘𝗅𝗺𝗵𝗂𝗃 So there it will cross, and after crossing it runs downwards to enter the cubital fossa. Okay, so it enters and it forms the medial most content of the cubital fossa region. So in the cubital fossa, here the median nerve, if you see, it lies medial to the brachial. This is the cubital fossa region here. So it will lie medial to the brachial artery and the tendon of the biceps here. So here the nerve is protected by the bicipital aponeurosis, which covers it and separates it from the median cubital vein, which is in the superficial part. So here this median nerve, it will give muscular branches. Okay, so if you see, it gives muscular branches from its medial aspect, supplying all the superficial flexors of the forearm. Okay, superficial flexors of the forearm, which includes the flexor 𝗕𝗵𝗂 radialis, then 𝗲𝗵 longus, flexor digitorum superficialis. Okay, so it supplies all the flexors of the forearm except for flexor 𝗕𝗵𝗂 ulnaris. Among the superficial flexors of the forearm, it supplies all except for flexor 𝗕𝗵𝗂 ulnaris. Okay, this is not supplied because this is supplied by the ulnar nerve. Then it will leave the cubital fossa by passing between the two heads of pronator teres. So this is the pronator teres muscle. So it leaves the cubital fossa by passing between the two heads of the pronator teres muscle. So here it will give a branch which we call it as the anterior interosseous nerve. Okay, anterior interosseous nerve. So this is given by the median nerve. So this anterior interosseous nerve, just like posterior, it is completely motor and it will supply the deep muscles. Okay, so it supplies the flexor pollicis longus as well as the pronator quadratus, and it will supply the lateral half of flexor digitorum profundus, okay, and the pronator quadratus. So these muscles are supplied by the anterior interosseous nerve. Then in the forearm, okay, so this is all in the forearm, the median nerve will pass downwards behind the tendon, okay, tendinous arch, that is a bridge between the two heads of the flexor digitorum superficialis, and runs deeper to that muscle and about 5 centimeter proximal. So this is the flexor retinaculum. About 5 centimeter proximal to that, the nerve emerges from the lateral side of the flexor digitorum superficialis. Flexor digitorum superficialis. It emerges from the lateral side, becomes superficial. Okay, and in the mid forearm, the median nerve will give muscular branches to the radial head of flexor digitorum superficialis muscle, and also it enters, after that it enters the carpal tunnel. So before it enters the carpal tunnel, it gives the palmar cutaneous. So this is the palmar cutaneous. So you have to remember that the palmar cutaneous, okay, the palmar cutaneous nerve, okay, which supplies the skin, okay, over the lateral part of the palm, that is basically over the thenar eminence, and the lateral part of the palm is supplied by this palmar cutaneous, and this palmar cutaneous nerve is given before it passes through the carpal tunnel. This is a very important point which you need to remember. And next in the palm, okay, so that is in the course in the forearm. Then coming to the palm, so once it enters the carpal tunnel and enters the palm, here it will divide into two divisions, the lateral division as well as the medial. So it gives two divisions, lateral and a medial division. So the lateral division will give a recurrent branch, okay, so it gives a recurrent branch which will supply the thenar muscles. Thenar muscles are supplied by it. Okay, so then it divides into, okay, then this lateral division, it will divide into, this is the lateral and this is the medial division. If you see, so lateral is supplying the thenar muscles. Then it will give 3 palmar digital branches. 3 palmar digital branches. Okay, 3 palmar digital branches, and the medial division will give 2 palmar digital branches. And it will also supply the first and second lumbricals. So these are the branches given by the median nerve. So these together, basically they will be supplying the skin over the lateral 3.5 digits over the palmar aspect. Okay, lateral aspect of the 3.5 digits, it is supplied by the median nerve. So that is about the distribution of median nerve in the palm. Okay, so the median nerve, once it enters the carpal tunnel, will divide into lateral and a medial branch. The lateral branch will give a recurrent, this is the recurrent branch, which will supply the thenar muscles, as well as it will also supply, it will give 3 palmar digital branches. So basically they will be supplying the adjacent sides of, so since it gives 3, okay, 2 will supply here, 1 along the lateral aspect of the index finger. Then we have the medial. So medial will supply the lumbricals, will give 2 muscular branches to the first and second lumbricals, and it will give 2. Okay, so it will supply the adjacent parts of the middle finger as well as the lateral part of the index finger. So that is how they supply the lateral skin over the lateral 3.5 digits once the median nerve enters the carpal tunnel. Before it enters, it will give the palmar cutaneous branch, which will be supplying the skin over the lateral part of the palm. So this is very important to remember. So that is about the course and distribution of the median nerve. So let's go to the injuries. Okay, so here you can see the median nerve dividing into, this is the lateral and this is the medial division. So lateral is giving, this is the recurrent branch, you can see. Supplying the thenar muscles here, and here you can see it is giving 3 palmar. Okay, so correct, supplying the adjacent sides of the thumb as well as the index finger. This is giving 2. Okay, 2, this is giving 3. 1, 2 and 3. So this will divide here, supplying the adjacent sides. So this is how the lateral 3.5 digits are supplied. So you can see. So this is mainly by the palmar cutaneous branch, whereas this distribution is by the, over the digits, is by the lateral and medial divisions of median nerve. So this is after it enters the carpal tunnel, and this is before the carpal tunnel. So this is one important thing which you should remember to understand the lesion. So if you see the injuries of the median nerve, so the median nerve is injured at 4 sites. Okay, so the injury of median nerve, we see it at 4 sites. One is, it can be injured at the elbow, that is in the cubital fossa region, then mid forearm, third at the wrist, that is distal forearm, and fourth importantly it is the carpal tunnel. Okay, so at the elbow. So if the nerve is injured at the elbow, basically the elbow, it is mainly due to supracondylar fracture of the humerus or during venipuncture. So usually we use the median cubital vein, right, for the venipuncture. So when we tie a tourniquet, okay, if the tourniquet is very tight, that can also lead to injury of the median nerve. And third thing is when the nerve is passing through the two heads of pronator teres muscle. So there also it can get entrapped, and that can also result in injury. So because of these three, supracondylar fracture or a tight tourniquet during venipuncture and compression of the nerve when it passes to the two heads of pronator teres, the median nerve is likely to be injured. So what will happen? Now median nerve, as we saw, it is mainly motor, right? It is mainly motor in the forearms. So through its main branch, that is through itself, it will supply all the superficial muscles for superficial flexors of the forearm except for flexor carpi ulnaris, and through its deep branch, that is the anterior interosseous nerve, it will supply the deeper muscles, deeper flexors, which includes the flexor pollicis longus, but here the flexor digitorum profundus, it will supply only the lateral half as well as the pronator quadratus. So these muscles are supplied by its branch, that is the anterior. So when the nerve is injured here, so there is complete loss of these flexors, right? So flexion is affected. So and because the pronator, okay, the pronator teres is affected, okay, pronator teres is also part of in the flexor compartment. So the median nerve, when it supplies the pronator teres too. So because the pronator, both quadratus as well as the teres is affected, pronator teres is affected, so what will happen? Pronation is affected. So because the pronation is affected, the forearm is kept in supine position. Okay, so the forearm will be, we see it in the supine, okay, supine position. Then the wrist flexion, the flexion of the wrist becomes weak due to paralysis of, here I am saying it is not complete paralysis is there, it is weak. Why it is weak? Which muscles are spared? Two muscles are spared. Which are those two muscles? One is so flexion is weak, flexion of wrist is weak, okay, there is no loss, it is just paresis is there. Paresis is weakness, paralysis is complete loss. So it is weak because of the sparing of flexor carpi ulnaris and medial half of flexor digitorum profundus. So these is spared because those two are supplied by the, which one? The ulnar nerve. So that is why, because of these two muscles action little bit, there is weak flexion. But there is no flexion at the interphalangeal joints of the index and the middle finger. Okay, index and the middle finger, there is no flexion. So two deformities are common in median nerve injury which we observe in the hand. So one is the benediction hand deformity. Now benediction hand deformity, in this what happens is when the patient is trying to make a fist. Okay, we ask the patient to make a fist, and then the index and the middle finger, okay, the index and the middle finger, they remain straight like this. So this we call it as the benediction hand deformity. Now why these two fingers are straight? Because the paralysis of both the superficial and deep flexors, okay, superficial and deep flexor, which is that flexor digitorum superficialis as flexor digitorum profundus. Okay, so the lateral half of the flexor digitorum profundus is there. So both these are paralyzed. Okay, because of that, what happens is these two fingers remain straight. And why not these two fingers? The ring and the little finger, that is because of the intact nerve supply flexor digitorum profundus, as well as we have the hypothenar flexor digiti minimi is also spared there. So because of which these two fingers are spared. Only these two fingers, they remain straight, okay, because of the involvement of both flexor digitorum superficialis and lateral half of flexor digitorum profundus. So this is known as the benediction hand deformity. Then we have loss of flexion, okay, loss of flexion. So thumb is also remaining is straight here, right? So why is that? Because of the loss of flexion of the terminal phalanx of, okay, because the flexor pollicis longus is also affected. There is no flexion of the thumb. So because of which these three fingers, they remain straight. So this is known as the benediction deformity of the hand. Then we see one more deformity, that is the ape thumb deformity, okay. So ape thumb deformity, here what happens is the thenar muscles are affected, okay. So here you can see the thenar eminence is, okay, the thenar eminence is flattened, and the thumb, okay, the thumb will be laterally rotated and adducted, laterally rotated and adducted. So thumb, there is lateral rotation and adduction. Okay, so this is mainly because of the paralysis of the thenar muscles. So this is the thing. And what will be the sensory loss? So this is all about the motor loss. What about the sensory loss? So sensory loss will be sensation. So where mainly the median nerve is sensory over the palm, right? So since the injury is at the elbow, even the 𝗲𝗪cutaneous branch is also involved. So there is loss of sensation over the lateral part of the palm as well as the lateral 3.5 digits on the posterior side up to the dorsum, this thing, that is the nail beds, okay, on the dorsum of the hand. Even it involves the nail beds of the 3.5 fingers, because that is also supplied by the median nerve. So that is about the sensory loss. So in the mid forearm, if it is injured, okay, so mid forearm injury, there it basically results in what we call it as the pointing index, okay. So mid forearm, it results in pointing index, and this is mainly due to paralysis of the radial head of flexor digitorum superficialis muscle. Okay, this is the main thing. Along with that, you will see all the rest of the things also, which we see, which occurs distal, whatever the supply is there distal to the forearm. Here, why only the index finger, why not the other was that is the middle finger here? Because if it is injury at the elbow, we saw the involvement of the middle also, right? There was in the benediction sign deformity. But here, it is only pointing index. Pointing index we will see in the mid forearm. That is because the ulnar head of the flexor digitorum superficialis is spared. Ulnar head will be supplied when it is in the cubital fossa itself. It will supply the ulnar head of flexor digitorum superficialis. Here in the mid shaft, the radial branch supplying the radial head of the flexor digitorum superficialis is affected. So you have to remember that pointing index is if there is a mid shaft, because the radial head is affected of the flexor digitorum superficialis. Rest of all those injuries, that is the sensory loss is there. There is weakness of the flexion of the wrist joint is also there. So that is about injury in the mid-arm. So the injury of the median nerve at the wrist, that is the distal forearm, okay. Here the median nerve and its 𝗲𝗪cutaneous branch is injured, okay. So this can be because of deep wound cuts like suicidal cuts and all those things. So characteristics deformity here will be the ape thumb. So we will mainly see this ape thumb deformity here, okay. Ape thumb deformity is mainly seen. Ape thumb deformity is the thenar eminence is lost, the thumb is laterally rotated and adducted, and that loss of sensation over the 3.5 digits we can see, as well as the lateral part of the arm. So here just keep in mind, when we have injury at the elbow, there is both 𝗘𝗵𝗃 and the benediction hand deformity. When there is distal forearm here, mid forearm, we have the pointing index, okay, pointing index deformity. And when it is in the distal part, okay, injury at the distal part of the forearm, there is 𝗘𝗵𝗃 deformity. Then the injury is main injury of the median nerve. We see it in the carpal tunnel. Okay, so carpal tunnel is basically the compression or the nerve entrapment injury here. So compression of the nerve in the carpal tunnel will result in carpal tunnel syndrome. So basically the carpal tunnel is formed by the concavity of the carpal bones as well as the flexor retinaculum, right? So that is the, here we have the carpal tunnel. So in this carpal tunnel, along with the median nerve, we have the tendons of the long flexor, okay, all the long flexes. Long flexes are present, the tendons, right, of this along with the median nerve. So this median nerve, it can get compressed in this tunnel due to its narrowing. So this carpal tunnel get narrowed because of many conditions, like one is tenosynovitis, okay, one condition is tenosynovitis. So tenosynovitis of the flexor tendons, okay, so tenosynovitis because these tendons are covered by the synovial sheath, okay, as they pass through this tunnel. So there will be inflammation of this and that can result in tenosynovitis. Then we have myxedema. Okay, so this is deficiency of the thyroxine, which we see it in adults. And then can be also in pregnancy because of the retention of fluid. Retention of fluid. Then there may be fracture and dislocation of lunate bone. Then osteoarthritis, okay, osteoarthritis of the wrist. So all this can be the causes of carpal tunnel. So here what will happen? One is because the nerve compression is there, okay, there is initially because of the compression injury, we will have the feeling of pins and needles, like burning sensation, pins and, so the patient comes with that history, there is burning sensation and sensation of pins and needles over the lateral part of the palm, maybe along the distribution, especially it will be more along the 3.5 digits, okay, it is in the, and they will complain it is more in the night. There is no sensory loss here, okay, there is no sensory loss over the palmar aspect. Why? Thenar eminence of the skin, because it is supplied by the palmar cutaneous branch before it enters, right, the carpal tunnel. And there is weakness of the, so that is the sensory part. So coming to the motor part, there is weakness of the thenar eminence. Why there is weakness of the thenar eminence? It is supplied by the recurrent branch of the lateral division. So median nerve, once it enters the carpal tunnel, what happens to it? It divides into lateral and medial branch. And lateral will give a recurrent branch supplying the thenar. So because of which the thenar, there is a weakness of the thenar muscles. So if this condition is left untreated, what can happen then? It can result, so because of the involvement of thenar muscles, the thumb will result in 𝗘𝗵𝗃 deformity where there is lateral rotation and adduction, okay. So that is what we see, okay. So we can see 𝗘𝗵𝗃 deformity in median nerve injury compression in carpal tunnel. So there is also, this is the Tinel sign, okay. So there is positive Tinel sign. So this is how we test there for the carpal tunnel. One is the Tinel test, this positive Tinel sign. So what is this positive Tinel sign? So percussion. So when we percuss, okay, over the flexor retinaculum, it reproduces the patient's symptoms. Okay, so there will be suddenly, there will be a lot of sensations over the lateral 3.5 digits and pain. So that happens here. So you can see here, compression will cause that burning sensations as well as the pain as pins and needle sensation along the distribution of the median nerve. So that is the Tinel sign. Okay, so usually all these things can be relieved. So the moment we release the compression, right, when we decompress the tunnel, immediately these symptoms are very dramatically reduced. Then we have one more thing, that test we do, that is the Phalen's test. Okay, so Phalen's test, what we do is we bring about the flexion of both the wrists together, like we opposite each other against each other for a minute. We keep it this way. So when we do like that, what will happen? It will again produce the symptoms, because see, you can see the compression here and it will produce the symptoms. So that we call it as the Phalen's test. So remember, Tinel sign and Phalen's test is both for median nerve. So basically here we tap, percus, reproduces the symptoms. In Phalen's we oppose at the wrist and that reproduces the symptoms. So this is about the, so here we bring about the flexion. So both will reproduce the flexion of wrist, will reproduce the symptoms. So this is all about the injury of the median nerve. Okay, so just to quickly recap, so median nerve injury can happen at the elbow, at the mid forearm, at the distal to the wrist, as well as in the carpal tunnel. So mainly at the elbow, when the injury is there. Okay, the motor loss, we see mainly loss of pronation. So the forearm is in, if there is loss of pronation, the forearm will be in supination, right? So there is in a supinated position. Then there is weakness of flexion. There is no complete loss of flexion, but there is weakness of flexion, because which muscles are spared? The flexor carpi ulnaris and the medial half of the flexor digitorum profundus is spared. So because of which there is no complete loss of flexion, right? So that is the in the palm. Okay, so when we come down here, the thenar muscle, thenar eminence is lost. Okay, because of the nerve supply, recurrent nerve supply to the thenar. As well as these two fingers, we see the benediction hand deformity, because the flexors, okay, the long flexors are affected supplying. Why not these two? Because these two are spared, because the medial half of the flexor digitorum profundus as well as we have the flexor digiti minimi, which are spared, which are supplied by the ulnar. Okay, so the names of the deformities what we see. Now at the elbow level, when we see the 𝗘𝗵𝗆 deformity, we see the benediction hand deformity. Okay, then mid forearm, we will see the similar things. Okay, we will see the similar things in the mid forearm also. And then distal to that mid forearm, one more thing is we see the pointing index, right? We see the pointing index finger. Pointing index here, not benediction hand, but pointing index we see mainly because why? Only the radial head of flexor digitorum superficialis is affected. Okay. And then when we come to the distal forearm, distal part near the wrist, okay, distal to the wrist, distal part of the forearm, here the 𝗲𝗪cutaneous branch, if it is involved, so then we see the loss of sensation over the palm, okay, as well as loss of sensation of 3.5 digits. The thenar eminence is lost, so 𝗘𝗵𝗆 deformity, loss of sensation we see. Okay, but those we do not see. What is that? Pointing index, because the flexor tendons are fine. Okay, they are supplied before itself, right? So it is okay. Then the main injury which we see is the carpal tunnel. Carpal tunnel, here the nerve can be compressed because of myxedema, retention of fluid in pregnancy. Then what else did we see? The tenosynovitis. Okay, so tenosynovitis, all this causes the compression there, and that can result in carpal tunnel syndrome. So carpal tunnel syndrome, so once the nerve enters, it is dividing into medial and lateral branches, so supplying this. So thenar eminence is affected, okay, and we see the 𝗘𝗵𝗆 deformity where it is laterally rotated and adducted, okay, loss of sensation over the 3.5 digits and sparing of the sensation over the palm. This is very important. In carpal tunnel, the sensations over the palm, lateral part of the palm is spared, because the 𝗲𝗪cutaneous branch is given before the nerve passes through the carpal tunnel. So we do two tests here. One is the Tinel sign, another one is the Valence test. So these are the things very important which you should remember about the median nerve. And the last nerve is the ulnar nerve. So we move on to the last important nerve, that is the ulnar nerve. So the ulnar nerve also comes from the brachial plexus, that is, it is a branch of the medial cord of brachial plexus. Medial cord of the brachial plexus. So it arises in the axilla. So what is the root value of that? C8 and T1. C8 and T1. Okay, so sometimes it also receives contributions from the ventral ramus of C7, and these fibers, they usually supply the flexor carpi ulnaris muscle. Okay. So now in the axilla, we will look at the course of the ulnar nerve first in the axilla. So in the axilla, the nerve will lie medial. Since it is coming from the medial cord, it lies medial to the third part of the axillary artery. And it enters the arm, okay, it enters the arm along the medial side, okay, along the medial side of the brachial artery, and up to the level of the, it will be lying medial here, okay, up to the level of the insertion of 𝗘𝗅𝗃𝗃, it lies medial, where it pierces. So if you see here, it is piercing the medial intermuscular septa, okay, this is the medial intermuscular septa, it pierces there, and it will enter the posterior compartment of the arm. Okay, so at this same level, the radial nerve will be entering the anterior compartment. So ulnar will go to the posterior compartment of the arm, and it will run downwards like this up to the medial epicondyle of the humerus, and on the back of the medial epicondyle, it is lodged in a groove. So here there is a groove, and this groove, okay, it is converted into a tunnel by a fibrous band, and that we call it as the cubital tunnel. Okay, so a fibrous band which extends between this medial epicondyle up to the olecranon process, right? So that band will convert this groove into a tunnel, and we call it as the cubital tunnel. After that, the ulnar nerve will cross the ulnar collateral ligament in the floor of the tunnel, okay, and it will enter the forearm. So in the axilla or in the arm, ulnar nerve is not going to give any branches. Even median nerve doesn't give, even ulnar nerve will not give any branches there. So nerve will enter, then it enters here the forearm, the anterior compartment of the forearm, by passing between the two heads of flexor carpi ulnaris. So here I just want you to recollect, okay, we studied radial nerve, median nerve and the ulnar nerve. So radial nerve passes through supinator, okay, radial nerve passes through supinator, median nerve passes through pronator teres, the two heads, whereas ulnar nerve passes through flexor carpi ulnaris muscle, okay, so to the two heads of flexor carpi ulnaris. Now in the upper third of the forearm, now this course we are studying in the forearm. In the upper third of the forearm, it will run almost vertically downwards under the flexor carpi ulnaris muscle itself, and in the lower third of the forearm, it becomes superficial, and it will be lying lateral, okay, so beneath it will be running below the flexor carpi ulnaris, and in the lower third it will become superficial and lies lateral to the tendon of the flexor carpi ulnaris. Okay, so it lies, the artery will be, so the nerve and ulnar nerve and ulnar artery, you can see it together in that region where the ulnar nerve will be medial, okay, ulnar nerve will be medial to the artery. So first will be the ulnar nerve, then will be the ulnar artery. Now in the forearm, it will give two branches. One is in the proximal forearm, it will give muscular branches to, so if you see here, it is giving branches to the flexor carpi ulnaris and medial half of flexor digitorum profundus, okay. So these. Then in the lower part, in the mid forearm, it will give 𝗲𝗲cutaneous branch. Okay, so this two branches here. So in the forearm lower part, it will give, one is the 𝗲𝗲cutaneous branch. Now 𝗲𝗲cutaneous branch will be supplying the skin over the palm, that is the medial aspect, over the hypothenar eminence and the medial part of the palm. Okay, skin over the medial part of the palm. Lateral part we saw median nerve, so the medial part it is mainly by the ulnar nerve. So it gives that, as well as in the distal forearm about 5 cm from the wrist, okay, to the wrist, it gives the dorsal. This is the dorsal cutaneous branch. So this dorsal cutaneous branch will be supplying the skin over the medial side of the dorsum of the hand and to the medial 1.5 digit. Okay, so this is on the dorsal side of the hand. Okay, so there it supplies the medial part as well as 1.5 digit. So this will supply the entire, okay, the nail bed region also is supplied by this. So this is in the forearm, and ulnar nerve, it is the main nerve of the hand. So if you see now from the arm, if you see in the shoulder region, it is the axillary nerve. Anterior compartment of arm, it is musculocutaneous. Posterior compartment of arm, it is the radial nerve. Then coming to the forearm, anterior compartment, mainly the nerve is the median nerve. Basically when I am saying here, it is the motor supply, and posterior, it is the posterior interosseous nerve, which is again the branch of radial. And when it comes to the hand, we have the ulnar nerve, main nerve supplying most of the muscles there. Okay, so ulnar nerve. So ulnar nerve, it will enter the palm. Okay, so here you should remember that it passes superficial. Okay, it will pass superficial to the flexor retinaculum. Okay, it passes superficial to the flexor retinaculum. It just lies lateral to the pisiform bone there. So here the ulnar nerve, no, it is covered by a ligament which we call it as the volar carpal ligament. Volar carpal ligament. Volar carpal ligament. So the space which is beneath that, okay, beneath that we call it as the ulnar tunnel. And distal to the pisiform bone here, the ulnar nerve will divide, okay, distal to the pisiform, here it will divide into two branches, that is the superficial, so superficial branch and the deep branch. So superficial branch is basically sensory, it will supply the palmar only one muscle, that is the subcutaneous muscle, which is the palmaris brevis, okay, so it supplies palmaris brevis and provide sensory innervation to the skin on the palmar surface of medial 1.5 digit. Okay, because palmar branch is already given, so it doesn't supply the skin here. The superficial branch will supply the skin over the palmar aspect of medial 1.5 digit. Okay, then the deep branch. So the deep branch will enter a canal which we call it as the Guyon's canal. Okay, it passes through the Guyon's tunnel. So it is Guyon's canal is formed by the 𝗨𝗲𝗏. It's also called as the 𝗨𝗲𝗏 tunnel. So it's a osteofibrous tunnel. Okay, osteofibrous or osteoneurotic we say, basically formed by the two bones, pisiform and hamate, and the fibrous band across that. Okay, the ligament across that. So it will pass through that tunnel, 𝗨𝗲𝗏 tunnel. Okay, remember here the volar carpal ligament, there it forms the ulnar tunnel. Okay, that is ulnar tunnel. This is Guyon's canal. Okay, 𝗨𝗲𝗏 tunnel is Guyon's canal, and there it will, okay, so it will form an arc like an along the concavity of the deep palmar arterial arcade. Along that it passes and it will end in the adductor pollicis, okay, pollicis muscle. So within the substance of the adductor pollicis. So here we see more. So superficial branch is supplying 1.5 digit skin over the 1.5 digit as well as the subcutaneous muscle, that is palmaris brevis. The deep branch passes through the Guyon's canal. So Guyon's canal, the deep branch passes, okay, remember that. Whereas the ulnar nerve as such passes through the ulnar tunnel. Here. So here this, okay, so it supplies the wrist joint. So this will be supplying the wrist joint. Then all the hypothenar muscles, that is the flexor digiti minimi, abductor digiti minimi and opponens digiti minimi, it supplies the hypothenar. The 3 palmar interossei muscle, the dorsal interossei muscle, the medial 2 lumbricals, that is 3rd and 4th lumbricals. Sometimes it also supplies the flexor pollicis brevis and adductor, hence in adductor pollicis. So these are the muscles supplied by the ulnar nerve. So if you see, mainly all the intrinsic muscle, okay, except for the thenar and the 1st and 2nd lumbricals, they are all supplied by the ulnar nerve. So ulnar nerve, we also call it as the musician's nerve, because these muscles, intrinsic muscles, are very much in action while we play the instruments, especially the string instruments, okay. Whereas the median nerve is known as the laborer's nerve, because the long flexor tendons, we use them to do any hard work like hold the plow or digging and all those actions. We are using the flexors of the forearm, right? So that is why we call that as the median nerve is called as the laborer's nerve, okay. It is also median nerve, one more thing I would like to mention here, it is also known as the peripheral eye, okay, or eye of the hand, because we try to feel the texture of any cloth or anything, right, with these thumb and the index finger, between these thumb and index finger, and this the skin over these part is supplied by the branch from the median nerve, right. So that is why it is also called as the peripheral eye. Whereas ulnar nerve, we call it as the musician's nerve, because it innervates most of the intrinsic muscles of the hand, which are involved in the intricate hand movement. And this ulnar nerve, when it passes behind the medial epicondyle of humerus, okay, it is also called the funny bone, okay, funny bone, because when the medial part of this elbow hits any hard surface, okay, there is some kind of sensation, that tingling sensation, right. Actually it is not a funny sensation, it is actually painful, but yet this ulnar nerve is known as the funny bone there, right. So this is about the ulnar nerve, okay. So we will move on to the sensory distribution. So that was the motor. Sensory distribution, if you see, it supplies the medial part, medial method of palm, okay, which is supplied by the palmar cutaneous branch, supplies this, and the 1.5 digit is supplied by its superficial branch. Okay, so that is the cutaneous distribution which we see. Coming to the injuries, okay. So the ulnar nerve is commonly injured at 2 sites, okay. The site of injury of ulnar nerve is, one is at the elbow and at the wrist. So the ulnar nerve can be injured at 2 sites, one is at the elbow and other one is at the wrist. So at the elbow, it is mainly because of fracture dislocation of medial epicondyle, of the humerus, and thickening. There is the nerve passes through that cubital tunnel, right? Cubital tunnel syndrome. So there may be compression because of the thickening of that fibrous band, which extends from the medial epicondyle to the olecranon process. Then as it passes from there to between the two heads of the which muscle? The flexor carpi ulnaris muscle. So there also the nerve can be compressed. Then there can be valgus deformity. Of the elbow, and that we call it as the tardy or late ulnar nerve palsy. Okay, we call it as the tardy or late ulnar nerve palsy. So these are the common causes of injury at the elbow. So what can happen? What are the characteristic clinical features? So what are the characteristic features here which we see? One is, okay, we will go from here, right? So the elbow, so in the forearm, the muscle is supplying only two muscles, okay, basically 1.5 muscle, that is the flexor carpi ulnaris muscle as well as the medial half of the flexor digitorum profundus. Its main supply is in the hand, right, in the palm. So there will be atrophy and flattening of the, so if you see there is atrophy and flattening. If you compare here, there is atrophy of this hypothenar eminence, okay. Then in the hand we see a deformity which we call it as the claw hand deformity. Okay, so this if only ulnar nerve is involved, we call it as the partial claw hand. Complete claw hand, both ulnar and median nerve, if they are injured, then we have a complete claw hand. Okay, so claw hand deformity here affecting two fingers. Which two fingers? The ring and the little finger. Okay, ring and the little finger are involved here. So here what happens? The first phalanges, okay, of these fingers are extended, and the middle and distal phalanges are flexed like this. Okay, so that is we call it as the claw hand. So loss of abduction. Okay, there is loss of abduction and adduction. Why? Because the palmar. Okay, palmar introche brings about pad, adduction. Okay, and dorsal introche brings about abduction. Okay, so both abduction and adduction is lost. Then a flattening of the hypothenar eminence, atrophy, I told you that. And what will be this? That will be about the motor loss. What will be the sensory loss? Sensory loss will be over the medial part of the skin over the medial part of the palm, as well as the skin over medial 1.5 digit. Okay, so there is loss of sensation. So in this case, there is a sign positive. Okay, I'll show you the test later. So a positive test, which we call it as the Fomen's test, Fomen's sign. Okay, so Fomen's sign is for ulnar nerve. So Fomen's sign, the patient is basically asked to grasp a card between the thumb and the index finger. Okay, and we try to pull it to see the power there. So between the thumb and the index finger, the patient is asked to grasp a card, and when the doctor pulls, okay, the flexion of the distal phalanx and thumb occurs. Okay, when we try to pull it, what happens? The flexion of the distal phalanx of the thumb occurs due to paralysis of adductor pollicis. Okay, due to paralysis of adductor pollicis, that is known as the Fomen's sign. I will show the picture and tell you again about it. The next injury is at the wrist, okay, where it can be because of entrapment, or it can be also because of injury at the wrist. Okay, so superficial, since it is superficial to the flexor retinaculum, right, so it is vulnerable to any cuts or anything there. Another thing is once it passes through the Ghayon's canal. Ghayon's canal is the 𝗖𝗵𝗂𝗧𝗏, okay, and which part of the ulnar nerve passes through that? The deep branch. So ulnar tunnel is the volar ligament below that, okay, below the volar ligament near the pisiform bone, where we have the ulnar nerve itself passing there, right, and then it divides into the superficial and the deep branch, and the deep branch will be passing through the Ghayon's canal. Ghayon's canal is the formed by the pisiform and hamate and the pisohamate ligament above. So where it passes there, it can be compressed, okay, and that can result in the compression of the nerve entrapment, okay. So here what can happen, again because of the same thing, we see the claw hand deformity, of course. Claw hand deformity is seen affecting the ring and the little finger, okay. But in this case, it is more pronounced when the injury is here. It is called as the ulnar paradox, okay, ulnar paradox, because the flexor digitorum profundus is not involved here. It is spared. Flexor digitorum profundus muscle is not paralyzed. So there is marked flexion at the distal interphalangeal joints. Then atrophy of the thenar eminence, of course, atrophy and flattening at hypothenar eminence, atrophy and flattening of hypothenar eminence we see. Then abduction and adduction, same thing is lost. Abduction and adduction because of palmar introche, abduction because of dorsal introche is lost, and Fomen's sign is positive, okay, Fomen's sign is positive. So as I told you earlier, when we say complete claw hand, okay, complete claw hand, there is a combined lesion of both median and ulnar nerve at the elbow. So there, true claw hand, that is, there is hyperextension at the wrist, okay, and metacarpophalangeal joints. At the metacarpophalangeal there is hyperextension, whereas there is flexion of the interphalangeal joint. So this is complete claw hand, okay. Whereas ulnar nerve claw hand, we call it as the false claw hand, or it's not a true claw hand, okay, it's a partial claw hand. So this is the Ghayon's tunnel where it can be compressed, nerve entrapment can happen. So this test we do where the Fomen's sign will be positive. So this is in normal, this is, yeah, so when we hold like this between the index, okay, which muscle is acting here? The adductor of the thumb, adductor pollicis of the thumb. So that should bring it closer here, right, when we try to hold like this. So between the index and the thing. But here what will happen, because the adductor pollicis is paralyzed, there is no power here. So to hold the card, what will happen? The thumb will flex here, okay. So that is why this is the abnormal, okay. So you can see the flexion, the distal phalanx of the thumb, okay. So the adduction is lost. So to hold it, otherwise it will adduct and hold like this, right, it will hold this way. But if there is no adduction is lost, if I have to hold, what will I do? I will flex and hold like this, correct. So that is the positive Fomen's sign, yeah. So here also when we have to do the pincer like this, okay, so there also we need to bring about the adduction. So that is again lost. So that is, you can see here the normal and the abnormal, okay. In the normal, this thumb will be straight, okay, there won't be flexion here. This is abnormal. And the nerve is here, the ulnar nerve is injured. So which muscle is paralyzed there? Adductor pollicis. This is normal. So when the doctor is trying to pull, okay, so you can see if it is flexed, it is abnormal. When it is straight, it is normal. This is called the Fuhrman's sign. So just to summarize, okay, we see in the hand because of the three nerves, okay. 𝗕𝗵𝗂𝗏. What is 𝗕𝗵𝗂𝗏? D is for drop hand, that is the wrist drop. Okay, wrist drop. We have the DR. R is what? So wrist drop, radial nerve. So this is the doctor. Claw hand, 𝗘𝗵 is C is claw hand. Okay, claw hand, which one? Mainly the ulnar nerve. And median nerve, we have the 𝗘𝗵𝗻 deformity. Okay, 𝗘𝗵𝗻 deformity. 𝗘𝗵𝗻 deformity will be like this. So that is just to remember the injuries. So let's look at some of the MCQs, image-based MCQs. So image shows a hand with hyperextension at the 𝗪𝗪𝗃𝗃 joint and flexion at interphalangeal joints of 4th and 5th digits. Okay, here hyperextension at the 𝗪𝗪𝗃𝗃 and 4th and 5th. So which, like this, it is the ulnar nerve. Yes, ulnar claw hand. Here, okay, ulnar claw hand. Median nerve, it will involve the 2nd and 3rd, not the 4th and 5th. Image shows patient asked to make a fist, but index and middle finger remain extended. Okay, what is that sign? Benediction, hand deformity, correct? Yes. So which nerve injury? It is the median nerve injury. So to the last question, image shows flattening thenar eminence, nerve affected. So flattening of the thenar eminence here, it is the median nerve. If hypothenar eminence, it will be the ulnar nerve. So that's a wrap on today's session on nerves of upper limb. Be consistent with the series because consistency is the key to success. I'll see you in the next session.